My name is Hank Hutchinson. I'd like to thank Dr. Rout for allowing me to participate in this webinar, and also nice presentation, Dr. Gary. I'd like to follow up with that with my presentation of the use of CurvaFix for a sacral insufficiency fracture. I'm in Tallahassee, Florida, a member of the Tallahassee Orthopaedic Clinic. My case is a 70-year-old female who sustained a ground level fall 6 weeks prior to seeing me and was treated at an outside facility about an hour and a half away. Prior to this fall, she was a community ambulator, used a walker occasionally, but typically a cane, was able to get up and get around and participate with her family. She was treated conservatively by another orthopedic surgeon, and after she was unable to ambulate after 6 weeks of conservative treatment, was then referred to me. Her past medical history is significant for cirrhosis, osteoporosis, and moderate obesity. On exam, she was noted to be neurovascularly intact. She had no anterior pelvic pain, either on palpation or with weight bearing, but she had disabling left posterior pelvic pain with weight bearing, which was requiring her to be in a wheelchair, and she was having pain while at rest and while rolling around in the bed as well, and was quite uncomfortable and had been for the last 6 weeks, despite attempting to rest and recover. CT scan obtained 6 weeks prior by the prior facility does show sacral insufficiency fractures on the left sacral ala. CT scans are shown here, and I've highlighted the fractures as they can be seen. Typically, this is something that is treated conservatively in the hospital with attempts to mobilize or as an outpatient. And if patients are able to mobilize, they can be treated without surgery, and that's typically what's done in my practice. However, this patient continued to have significant pain and inability to bear weight at 6 weeks post-injury, even disabling pain. These are x-rays from the office and AP pelvis, which shows some calcification in the parasymphyseal region. Obviously, due to her body habitus, it's very difficult to discern anything from the sacrum. Here's her inlet view that shows no significant displacement in the posterior pelvic ring. And her outlet view, which shows similar findings. So treatment options at this point, discuss this with her like I do most patients, what they should be. The need for additional imaging, we discussed possibly repeating the CT scan, getting a bone scan, getting an MRI. I think at this point, due to her clinical findings of severe pain that were localized to the left side of the posterior pelvis that was causing her an inability to bear weight, and a prior CT scan showing the insufficiency fracture, that we did not need any more additional imaging at this point. We could continue conservative treatment, but this takes significant amount of time and continued immobility and all the things that go along with old folks being immobile. Osteoporosis treatment, there are some studies talking about medical treatment of osteoporosis for non-unions or sacral insufficiency fracture. This does take a significant period of time. As someone who's a marginal ambulator, pre-injury, this would likely prevent her from walking significantly in the future if we would give it significant time. We talked about the option of posterior surgical stabilization and that there is a potential for quicker mobility, pain relief versus the risks of anesthesia and surgery. We had a long discussion with both her and her family, and they decided they wanted to proceed with surgical stabilization of her posterior pelvis. The options at that point that we all know who do this for a living are screws, plates, and now the CurvaFix. We talked about the device specifically and agreed to proceed with this. So this was scheduled as an outpatient the next week. She came into our hospital as an outpatient, and this is her in the operating room, supine position, C-arm images I'll show you. Those of us who instrument the sacrum, typically we're going to start with an AP and work between the inlet and outlet views. And I've got several shots here, primarily inlet views showing the passing of the CurvaFix, which I'm sure is similar to what has been presented in previous talks. The starting point on the lateral view, you can typically start much more anterior and inferior, which enables you to get a good curve in the implant. As the device is passed, you can see there's the tool which allows you to advance it in a curved fashion. The introducer is actually inside the ilium right there. And then using fluoroscopy and guiding the wire with a mallet, you're able to advance it across the sacrum and across the contralateral ilium. Typically in older osteoporotic patients, I've found that it can be difficult to get purchase in the contralateral ilium if there is a good corridor for a straight screw. This is measuring for the length of the screw, reaming over the guide wire, and placing the implant over the guide wire, the straight guide wire, which was swapped out before the screw was placed. This is advancing it to the contralateral ilium. There was surprisingly good purchase at this point, and as the screw compressed the back of the pelvis. This is our final inlet view with the C-arm right here, an AP pelvis, and the outlet view. So those are all my intraoperative shots. She got up, went home that afternoon. This is our post-op AP showing appropriately positioned implant with a good curve in the implant. You can see it's well contained within the sacrum on the inlet view with no violation of the sacrum anteriorly or posteriorly. You can see it's well in between the L5 S1 end plate and well above the S1 foramen. The interesting thing about this patient is, we went and saw her after surgery and she felt immediately different and more stable. She didn't get up and dance, but she couldn't get up and dance before the surgery either. So, but she did have significant pain relief. She was able to ambulate with a walker, which she had not been able to do before the surgery. And at 2 weeks when we saw her in the office, she was almost back to her baseline of getting around with the cane and the walker occasionally, and she was able to sleep comfortably. This is her at 7 weeks, the AP pelvis, which shows similar finding, no change in position of the implant, no signs of loosening or lucency. There's been no change in the curve of the implant. And she continued to progress well, and at 7 weeks was back to her baseline pre-fall. So I think for me and my experience, the CurvaFix advantages for sacral insufficiency fractures are that it can be done as a minimally invasive outpatient procedure. This patient was not a candidate for our ambulatory surgery center, but had she been, I would have likely done it there. It can allow for significant pain relief in the appropriate patients. You are able to use it with abnormal sacral anatomy. Can provide stability even in osteoporotic bone. Safe when appropriate imaging is possible, just like any sort of iliosacral screws. Should be used with appropriate treatment and counseling for osteoporosis as indicated. So I think it's important to remember as orthopedic surgeons, sometimes we're the first people to talk to people about osteoporosis. And this can't be a replacement for that counseling and treatment that needs to occur either from their primary care physician or their endocrinologist. And it can be used in multiple other corridors in the pelvis. Thank you.